The American College of Radiology.
Focused, forward.
Together.
Welcome to this ACR webinar on O-Rads Ultrasound applying version 2022 in daily clinical practice. Hi, I'm Lori Rakowski from the University of California, San Francisco, and co-chair of ACR O-Rads. I'm going to be joined today by Dr. Katie Phillips from Vanderbilt, co-lead of ACR O-Rads Education. We have no relevant financial disclosures. In the next 60 minutes, I'm going to give you all the basics, the why, when, and how to use O-Rads with a big emphasis on the lexicon and an algorithmic approach. And then I'm going to turn it over to Katie for some case examples to put it all together. So why do we need O-Rads? Well, we need O-Rads because ovarian cancer exists. Although relatively rare, it is often lethal, accounting for the 5th leading cause of cancer deaths in women, typically affecting women greater than 50 years of age, around 50% of whom will die within 5 years of diagnosis. As was the case for this unfortunate patient of my former chief, Dr. Ernie Ring, an interventional radiologist, who drew this self-portrait depicting her trials and tribulations with ovarian cancer before succumbing to the disease. Now, while outcomes are often grim, prognoses may be improved if initial surgery is performed by a gynecologic oncologist. So when ovarian malignancy is suspected, it is really important to triage patients appropriately from the get-go. Now, on the flip side, most surgically excised adnexal lesions turn out to be physiologic or benign, which isn't surprising considering the ovary is a very physiologically active organ with support follicles competing to become the Graafian follicle, erupting to become a corpus luteum, and occasionally resulting in hemorrhagic cysts, which can create a confusing picture, leading to unnecessary surgery, which is not without risk, leading to significant morbidity in up to 15% of patients who undergo this surgery. So here lies the rub. While we do not want to overcall lesions, we certainly do not want to miss a cancer. And things really fall apart when we, as radiologists, use descriptors such as complex, heterogeneous, or indeterminate, and conclude with cannot exclude malignancy for all lesions that are not simple cysts, although they have vastly different outcomes. These terms are just not helpful. We can and should do better, and O-Rads offers us the opportunity to do so. So the intent of O-Rads is to standardize our imaging terminology, provide a risk of malignancy based on imaging features, and guide management, both imaging and clinical. There are 2 arms to the O-Rads system. Ultrasound is considered first-line imaging, with MRI reserved as a secondary problem-solving tool. Both systems have different components. They offer governing concepts, which are the rules for system use, lexicon terminology, assessment categories with risk of malignancy. The ultrasound side offers management recommendations, but those will be coming soon for MRI. So let's talk O-Rads Ultrasound. Now, the basis for the system, we looked for our lexicon terminology for lesions from the IOTA International Ovarian Tumor Analysis Group. And for our classic benign lesions, we turned to the literature for those that were evidence-based. We then match those terms against outcomes data for surgically excised lesions to come up with these categories where malignant was considered either borderline low malignant potential or frankly invasive disease, falling into these groups, which gave us our O-Rads ultrasound categories, where 0 was technically incomplete, 1 is a normal ovary, 2 almost certainly benign with a less than 1% risk of malignancy. When there was 1 to less than 10% risk of malignancy, that was considered O-Rads 3 low risk. 4 intermediate risk is 10 to less than 50%, and 50% greater risk of malignancy was an O-Rads 5 high risk. Now, keep in mind that the likelihood of benignity is listed here. And so when you call a lesion, for instance, an O-Rads 3 low risk, and it turns out to be benign, instead of thinking, oh, O-Rads, called it possibly malignant, really that was the expected outcome. There was a greater than 90 to 99% chance that that was going to be benign. So the goal of the ultrasound side of things is really high sensitivity. So how have we done since that initial risk stratification paper was published in early 2020? Well, in terms of reproducibility, we've had excellent inter-observer reliability, both with minimal training and regardless of experience level. O-Rads Ultrasound has had a solid performance with greater than 90% sensitivity when using O-Rads 4 as the cutoff for malignancy, which is better than a lot of the other systems out there. Specificity has been moderate at 80%, 30% predictive value for malignancy. And that's in large part because the malignancy rate for our O-Rads 3 and 4 lesions are turning out to be at the lower end of that risk of malignancy range. There was a recent meta-analysis that looked at over 18 published studies, over 11,000 lesions, and again, very high sensitivity at 96% with a specificity of 77%. Now, while things are looking pretty good, people had a lot of questions about, why do you differ from SRU? How do I apply this in all of my ultrasound reports? Why do some of your terms differ from O-Rads MRI? What about shadowing with a solid fibroma? So we went back to the drawing board and tried to address all of these in this most recent version, which is version 2022, because that is when ACR adopted it. The publication just came out this past fall, with our aims being to further clarify the applicability criteria, some definitions, better align with SRU and O-Rads MRI, improve specificity of some of those lower risk lesions by adding some lexicon terminology, and then directing management that was more in accordance with the results from those validation trials, as well as clinical practice patterns. From here going forward, all of the updates I'm going to highlight in yellow. So those are of you that have been using the prior system can be aware of what's different. If you've never used O-Rads Ultrasound before, that's fine. I'm going to cover all of the nitty-gritty. So for our categories, nothing has changed in terms of the numbers or the verbiage or the risk of malignancy. For the management, for the technically incomplete exam, before we said alternate study, now we are saying repeat ultrasound or MRI. If you think those technical factors are going to change, you can try repeating it. If not, and you think, for instance, that the lesion is too large to get good assessment, you might want to go straight to MRI. For the normal ovary, no follow-up, no change. For O-Rads 2, there's a lot of lesions in this category, and hence we have a lot of different management strategies, all the way from none to, in some specific scenarios, getting an MRI. For those that are undergo ultrasound surveillance, there was a big request for some parameters around that. So we're now giving you some guidance where the initial study will be done somewhere between 6 and 12 months, can always be done earlier if needed. Interval will be at 12 or 24 months, but 24 months is going to be the maximal duration. Previously, it was 5 years. Then it's really up to the gynecologist to decide what to do. We're also giving you some growth parameters with something called the average linear dimension, and I'll go more into that later. We've also added some clinical guidance. Before, we didn't have any for the O-Rads 2 category, but some of these in this category, such as endometriomas, may need some clinical attention. Now, for the low-risk category, this is probably the biggest change in management. Before, we said ultrasound specialist or MRI. Most of these lesions were being assessed with MRI, but the validation trial results really did not support that. So if the lesion is unexcised, if that is not what the patient wants, you can perform ultrasound surveillance within 6 months, and then again at 12 and 24 months from the initial exam, and then per the gynecologist. With the caveat that if it's a solid lesion, that is where MRI has higher specificity for solid tissue and where you want to consider that. But a general gynecologist can manage these patients. For the O-Rads 4 category, again, ultrasound specialist or MRI, as we previously had in the initial O-Rads ultrasound scheme. However, we've now added that since these patients are going to be consulted or get a consultation with a gynecologic oncologist, they may have their own protocol and choose what they want the next imaging to be. For the high-risk category, previously we just said gynecologic oncologist, leading some to believe that there was no intent to get additional imaging. That was not what we meant by that. So we've clarified that is for both imaging and clinical, where sometimes they may want an MRI for further characterization, and other times the patient can go straight to CT for staging. So when should you use ultrasound? For this, we turn to our governing concepts, and the first several have to do with applicability criteria. So we wanted to make clear that before O-Rads just applied to ovarian or adnexal lesions, now you can also apply it to the normal ovary. Most importantly, though, you're going to use O-Rads when the intent is to stratify risk of malignancy. So it's not going to apply to those conditions such as PID, ectopic torsion, or an exophytic myoma, because we're not worried about malignancy in those scenarios. If you can't tell where the lesion is coming from, you might want to consider a CT or an MRI. If you want to incorporate O-Rads in all of your pelvic ultrasound reports and you don't see the ovary or it's absent, you would just say O-Rads not applicable, reserving the O-Rad 0 technically inadequate category based on the indication and expectation. So for instance, if you have a premenopausal patient, you're expecting to see the ovaries and she's there for ovarian cancer screening because she's high risk, you might want to consider it. For multiple or bilateral lesions, you're going to categorize those separately. And while management will be driven by the highest score, we've added to provide recommendations for each as needed, just to make that clear. Sometimes that will be applicable. Now, for definitions, menopause is still defined as amenorrhea for 1 year or greater. And there was questions about why we didn't include early and late menopause as they did with SRU. So we have added that with the same criteria as less than or greater than 5 years. And we've also added some age criteria if the woman is uncertain about her menopausal status or if her uterus is surgically absent. For the ultrasound specialists, which the definition is the same as a physician whose practice includes a focus on the appearance of adnexal lesions. While there are no mandated requirements or guidelines, although people really wanted to know, how do we get this branded across our forehead? It was really hard to come up with something that could be applied across all practices. But what we did want to emphasize that it's all about experience that's going to improve your likelihood of a correct diagnosis, which often includes participating in those QA activities such as tumor board, CME courses, etc. So for technique, transvaginal is generally what we're going to be using. We had in there that transabdominal or transrectal may add characterization. We kind of took away transrectal because that's not very common, but we really wanted to emphasize that transabdominal may suffice when transvaginal is not feasible or limited, because some people thought before that if you didn't perform transvaginal that it needed to be a technically inadequate exam. That is not true. As long as you get adequate characterization, that's fine. We also have currently added that cine clips are strongly encouraged, and let me show you some examples why. If you didn't get a cine clip of this lesion, you might think it's a simple cyst, but looking carefully, there was that little guy right there, that small papillary projection that could be easily missed. Here's another example where my sonographer brought this in, thought that this was an irregular or thick septation. I looked at the cine clip to appreciate that this was partial volume averaging. When I looked at the cine in the orthogonal plane, I could really appreciate that this was thin and smooth, totally changing the assessment category. Now for lesion size, we're still going to be using that single largest diameter when it comes to scoring. So that number that you see on the charts, that is the largest size regardless of the plane that it occurs. So you really have to twist the probe and elongate on it. Now, when you're going to have a prior exam and you're comparing that, we realize that if you only use the single largest diameter and you had a cystic lesion, depending on how much you pushed with the probe, it could deform that, creating a change that really wasn't real. So we've added for interval change, you're going to want to use the average linear dimension, which is the sum of the 3 largest orthogonal dimensions divided by 3, very similar to a mean sac diameter. And so you want to report all 3 dimensions if ultrasound surveillance is a management option. In terms of system use, the Lexicon and scoring apply to most lesions, regardless of risk or symptoms. Some people thought before that it was not applicable in high-risk patients or if they had symptoms. That is not true. When features are mixed or variable, you want to use the higher score, again, not to miss a cancer, but it's the management that's going to be modified in the setting of high-risk symptoms, clinical context, etc. So how should you use O-Rads? And I have 2 big tips for you. One is you want to learn the lexicon, learn the language, and 2, you're going to cheat. And by that, I mean you're going to use these cheat sheets, our charts, or the app. So we have these color-coded charts, just like they have for all of the RADs, where in the first columns, you have the O-Rads numeric score, the risk category verbiage, as well as the risk of malignancy. In the center, we have our Lexicon descriptors and size criteria with a glossary that's now added at the bottom with some definitions. And then we have our management strategies with all of those surveillance criteria that I just went over at the bottom listed here. Now, almost everything fit on this chart except for our typical classic benign lesions. And so we had to go on this additional chart, but it can all be found here. So let's talk lexicon. Use your words, right? So in general terms, physiologic things are those that we expect in a menstruating woman, whereas anything non-physiologic is called a lesion and not a mass. Because if you said, for instance, that there was a cystic mass, that might sound more ominous than using the word cystic lesion. For our classic benign lesions, these are ones that are benign. They may be non-physiologic and non-neoplastic or benign neoplasms, but typical features are established in the literature, and when you see them, they are considered a classic benign lesion. We are using the color score in O-Rads, which is borrowed from IOTA. This is a subjective assessment of degree of internal vascularity. It is a numeric system from 1 to 4. Now, for the 1 and the 4, these are pretty obvious. 1 is when there's no flow, and when there's very robust flow, you're going to use color score 4. When you have to really struggle, and it's you see this very tiny amount of flow, either in a solid component or in a septation, that would be a 2, minimal flow. But when you turn on the color Doppler box and you're seeing, yeah, there's flow, that's going to be a color score 3. Now, I don't have time to get all into the technical considerations, but you really want to optimize those settings, adjusting them to a low scale, and really important to use a small Doppler box that's just to your region of interest. So here's an example with a big box and just a smaller box. That's all that was changed to really bring out the flow within that solid component. I want to caution you against streaming and flash artifact. Streaming artifact occurs when you have mobile echoes. So while this might initially look like a solid lesion, on your cine clips, you appreciate that those are just mobile echoes, and as they move, they create this streaming. Occasionally, just with the patient's respirations, it can create a flash artifact because of that motion. So spectral Doppler can be helpful to determine whether or not it is true flow. Otherwise, spectral Doppler doesn't really play a role in O-Rads. We have some definitions for our associated findings of ascites. This is more than a physiologic amount. It needs to be quite a bit of fluid. And then peritoneal nodules may be either these solid or cystic deposits that occur along the peritoneal lining. Moving on to our actual findings, the follicle and the simple cyst, I'm going to bring them up here together because they really have the same descriptors. They are unilocular, anechoic, and have smooth inner walls. When you call it a follicle versus a simple cyst is going to depend on the menopausal status and the size. It is a follicle in a premenopausal woman when it measures 3 centimeters or less. Otherwise, it's a simple cyst. Our corpus luteum is our other physiologic cyst, which is thick-walled, may have a smooth or a crenulated inner margin, may be anechoic, or have these internal echoes representing blood products. When you don't see that central cystic component and the walls are opposed, it may be solid appearing. And this is really where color Doppler plays a super important role, because we're going to appreciate this robust peripheral vascularity to tell us it's a corpus luteum. Now, in version 2022, we are adding that the size criteria is typically 3 centimeters or less, because we want to make it clear that it's the morphologic features that are going to supersede the size criteria. If it meets morphologic criteria, you're going to call it a corpus luteum. You want to avoid the term corpus luteal cyst. Again, the term cyst, some people may take as something bad, but these are physiologic findings. In fact, for all 3 of these lesions, when all of the criteria are met, you can just say follicle, simple cyst, or corpus luteum. First name basis. Our Cher, Beyonce, and Oprah of O-Rads. If you say their first name, everybody knows who they are. All right, our classic benign lesions. We have 3 in the ovary and 3 that are extra ovarian. Starting with our hemorrhagic cyst in the ovary, we have added this locularity requirement that it is unilocular. And we did this because we didn't want people to confuse these thin, fine intersecting lines as septations. These are the fibrinous strands that we are going to describe using the term reticular pattern. We've also added there should be no internal vascularity, so that when you're seeing things like this, so you don't think that they're a solid component, there should be no internal flow and should have these straight or concave margins. If you can't tell if it's a solid component, applying a little bit of probe pressure to see that this is actually gelatinous, that this is clot. This is not a solid component. All right, for our dermoid, should be 3 or fewer locules and no internal vascularity, along with one of the following. You can have these hyperechoic lines and dots, which is coiled up hair. For the hyperechoic shadowing component, it may either be regional with this shadowing or may comprise the entire lesion. So that's why we added regional or diffuse. When you see these floating echogenic spherical structures, it's very pathognomonic for a typical dermoid cyst, though they are quite uncommon. Now, the endometrioma, the hallmark feature are these homogeneous low-level or ground glass echoes. The locularity, again, should be 3 locules or fewer and no internal vascularity, though a little bit of flow in this, quote, intervening septation, which is probably just some intervening ovarian parenchyma, is okay. We've added these peripheral punctate echogenic foci, again, not commonly seen, but when you see it, it's pathognomonic for an endometrioma, representing some cholesterol within this hemosiderin breakdown products. All right, for the extra ovarian, we have our para-ovarian cyst. When you have a simple cyst that is separate from the ovary, it needs to be simple. Otherwise, you have to use the other descriptors available for the ovary. If you're not certain if it's exophytic or really para-ovarian, applying some probe pressure to watch them separate can be useful. For the peritoneal inclusion cyst, it's not really a cyst, but a fluid collection that the ovary is either suspended within or eccentric, but it conforms the adjacent pelvic organs, and you may see these internal septations that represent adhesions. These occur in the setting of a prior inflammatory or process or surgery. You have to be careful to recognize that when you see something like this, you don't call it a solid component. Look for the follicles to appreciate that that is indeed an ovary. Now, for our hydrosalpinx, we added a term anechoic. We inadvertently excluded that before, but this is when you have this fluid-filled tubular structure separate from the ovary. Optional to see these incomplete septations representing folds, or occasionally seeing these endosalpingeal folds, which are these equidistantly spaced little nubbins around the periphery, sometimes better appreciated in the axial plane. I really like cine clips for these to really demonstrate all of these features. And there you have it. Those are our classic benign lesions. Really important that if you have to appreciate these, and that's the key to O-Rads success. You want to describe them, characterize them before you go on to the other lexicon descriptors, or else you risk upgrading a lesion. And in order to bowl your strike, we're going to give you some bumper rails here, and that if features are only suggestive and your overall assessment is uncertain, you're going to consider ultrasound follow-up within 3 months. For any atypical features, either on your initial or follow-up exam, you want to assess using our other lexicon descriptors, such as cystic, with or without solid, etc. And this is where I think O-Rads really shines and differs from a lot of the other systems. This is where SRU stops and where O-Rads kind of begins, if you will. We have these 5 categories, which would be pretty simple to put all of the other lesions into. Either they're cystic without septations, with or without solid components, with septations, with or without solid components, or it's a solid or solid appearing lesion when there's 80% solid tissue or greater. Now, for both solid lesions and solid components, this is going to exclude our blood products and our dermoid contents. So let's start with the solid appearing lesion. Not only are there the fewest things to look at with these, But they're also the most important because of the high-grade serous carcinoma, which accounts for 50 to 60% of all malignancies. These are not believed to evolve from our lower-grade serous neoplasms, but arise from these fallopian tube precursors called stiff lesions, and these are predominantly solid. So we really want to keep an eye out for these solid lesions. When you encounter a solid lesion in the adnexa, the first thing you want to look for is the outer contour. Is it smooth or irregular? And irregular would include a lobular outer contour. When it's irregular, that is suspicious enough to make it an O-Rads 5 and you are done. If it is smooth, you're going to go on to look at the degree of internal vascularity. If it is very strong, you are done. If it's less than that, you're then going to look at something called posterior acoustic shadowing, because this is a good feature often seen with our benign fibromatous lesions. Now, to qualify as posterior acoustic shadowing, it needs to be a lot. It needs to be diffuse or broad and should not be confused with refractive artifact that typically appears either at the edge or kind of from the center of the lesion. And that's it for our solid lesion. For the cystic lesions, there's nothing complex about it, and all pun intended. Remember, we're not going to use complex. So the first thing we're always going to look for is there a solid component? And you're going to determine that by the height of or the protrusion within the cyst cavity needs to be 3 millimeters or greater. So that's where you want to put the calipers. This is not about the largest diameter. You don't always have to measure it. Sometimes it's very obvious, as in these examples, but if you're on the fence, that's how you want to measure it. Now, an important subcategory of the solid component is the papillary projection that is relevant for our unilocular cystic lesions. It has the same height criteria. However, in addition, it's going to be surrounded by fluid on 3 sides. There may be one, there may be a whole lot of them, and the size matters, but we're not going to make you count them all. It's really about one of 2 buckets. Is it less than 4 or more, to determine whether it is O-Rads 4 or O-Rads 5. Next, you want to look at how many complete septations there are. Are there none? It's unilocular. We've added bilocular, which is 1 complete septation, in order to align with the SRU consensus on adnexal cysts, which then made us have to redefine multilocular, which is now 2 or more complete septations. For all multilocular cystic lesions, we're going to assess the degree of internal vascularity. And then when you have no solid components, you're going to look at the internal walls and the septations, whether they are smooth or irregular. So smooth would look something like this. For irregular, this is when you have focal thickening that measures less than 3 millimeters, again, either on a wall or a septation. If it was more than that, it would be considered a solid component. When it's irregular, you're done. However, when it's smooth, you go on to assess the internal contents. Either it is simple because it is anechoic, there are no echoes, or it's non-simple. And it's either non-simple when there are internal echoes that are scattered. These are ones that are not considered the homogeneous low echoes or the, hyperechoic lines and dots, or there can be an incomplete septation. That would also fall into a non-simple cyst. And if you haven't caught on by now, there's a really important thing here, in that it was a light bulb moment for us to realize that not every feature matters for every lesion, and how we could apply this algorithmic approach. So we always, when we risk stratify, want to put it in one of these initial 3 buckets: normal ovary, classic benign lesion, or other lesion. For the normal ovary, there's either no focal observation or there's one of these physiologic cysts, and those are all O-Rads 1. For the classic benign lesion, all the extra ovarian ones are O-Rads 2, regardless of the size. For the ovarian ones, we're going to use a large size cutoff of 10 centimeters to determine whether it's O-Rads 2 or 3. For the other, is it cystic or solid? If it's cystic, is there a solid component? If there's not a solid component, smooth or irregular. If it's smooth, are there septations? If there's not, or just one, we're going to use that large size cutoff. But once it's multilocular, we go to color score and then size. Irregular, are there septations? Size doesn't matter, color score doesn't matter. For the solid components, it's about, is it unilocular or do we have 1 or more septations? Because we're going to look at different things. For the unilocular, again, it's all about the papillary projections. whereas when it's bi or multilocular, it is about the color score. Size criteria does not matter here. For the solid, smooth or irregular outer contour, if it is shadowing and has less than very strong flow or no flow at all, then it is an O-Rads 3. If it is a color score 2 or 3 without shadowing, it is an O-Rads 4, and then very robust flow or an irregular outer contour is a 5. Caveat to this whole thing is if you have unexplained ascites or peritoneal nodules in an O-Rads 3 or 4 lesion, you're going to want to upgrade that to a 5. But if you categorize the lesion as 1 or 2, you have to consider other etiologies of your ascites or peritoneal nodules. And we have this algorithm posted for you on the website. I encourage you to print it, laminate it, keep it handy at your workstation. You can quickly get to an O-Rads score in a matter of seconds. Now, unfortunately, we don't have the management strategies on that. You're going to have to refer to the charts. Once you get familiar with the system, it will become rote to you other than the 2 category in terms of the management strategies. For the 2s, there's a lot of lesions. You're going to have to look at the charts, or you can turn to our app, and this thing has superpowers. So it's available on both iPhone and Android. You can search ACR O-Rads or O-Rads, download it, click on your RADS link here anywhere on this O-Rads Ultrasound, and then you will then ask just the features that are relevant based on your previous selection. You should be able to get to an O-Rads score or your management recommendations in under 30 seconds. We have this breadcrumbs that is an active field showing your last selection, and you can change those to just kind of play around with it. If you want to see any image examples, you just hit that pick icon. You'll see some image examples. You can spread your fingers to see those kind of magnified. On every single page now, you can easily access those charts, those tables, as well as having this link to the resources, which includes a link to the full O-Rads website. Now, on this website, we've got a lot of great implementation tools, including some report templates. So speaking about how to report, we always want to encourage you to order from most to least concerning. Only the relevant features are required, so less is more. You always want to report the numeric score for both the categories and the color score, but include that verbiage and or a legend because we don't expect our providers or patients to know what those numbers mean. You also may want to consider a reference such as the O-Rads ACR website for more information. And this is an example of a very basic template where you're going to give the location, the size, just those lesion-specific descriptors and whether or not there is ascites. If you have more than one finding in your report, you might want to number the observation and give the category and the findings as well, just to make sure that it's all clear. But most of the time, you're just going to include that O-Rads number within the impression. You don't have to repeat everything. You can just say as described above, or you can use the number and then include a glossary like this. Again, optional to include the risk of malignancy. I kind of tend to use this more with our lower risk lesions just because patients often have access to the reports even before the providers. So now it's time to turn it over to Katie Phillips, who's going to demonstrate some cases and how to put this all together. So take it away, Katie.
Well, thank you so much, Lori. Now we're going to transition to doing some cases of how to use O-Rads ultrasound in clinical practice. The goal of this section is to strengthen your knowledge and familiarity with O-Rads ultrasound version 2022 system and governing concepts through case examples. And in these cases, we're going to review the images, we'll talk about the lexicon descriptors, assessment categories, and management, and even include some sample wording for your reports. So let's jump right in. This is case 1. This is a 36-year-old woman who's coming in with abnormal uterine bleeding. And during our exam, we found this lesion in the right ovary. And what you'll notice is that there's a thick wall, but it has a crenulated inner margin. There's some internal echoes, and when we throw on color Doppler, we see that there's peripheral color Doppler flow, but no flow centrally. This is your classic corpus luteum, and if you're ever questioning what the definition is, we've actually included that here in the black text underneath the header on the app. So we'll include it in the report, O-Rads 1, corpus luteum. Now, do you actually have to include it in your report or even mention the score? The answer is no. But it's optional, and I would encourage you to consider including it for high-risk patients that are there for ovarian cancer screening, or if it's a finding that was found on another modality and this was the end result of the workup. Great. Next case, case number 2. This is a 40-year-old woman coming in for infertility evaluation. And what we have here are grayscale static and clip images. So I like to just highlight the fact that I strongly recommend sending clips in orthogonal planes through the entirety of the lesion to ensure that we don't miss small solid components and that we're really characterizing the lesion fully. And here we are. What we have is a simple cyst. Measures 7.1 centimeters. This is an O-Rads 2. And so in your report, you don't actually have to go through all the different features. You don't have to say it's unilocular, smooth inner walls, anechoic. The truth is it meets the criteria, then you can just say simple cyst. That's because we already have that definition, right? So what about management? Well, to get to management, we're going to pull out our handy dandy calculator. Certainly this is ovarian. It's not follicle or corpus luteum, it's too big, right? So we're going to click on lesion, simple cyst right there, again, with the definition under it. She's 40 years old, she's here for infertility evaluation. Click here, this meets criteria as an O-Rads 2, almost certainly benign lesion, for which follow-up ultrasound can be performed in 12 months. Now notice there's an asterisk, and that asterisk is really important and says that follow-up can be shortened in certain scenarios due to clinical factors, right? Well, this highlights governing concept 9, where management can be modified by risk, symptoms, and clinical factors, as well as professional judgment, etc. And we have a clinical factor here. She's here for an infertility evaluation, and she really can't wait 12 months. They need to know now if this is going to go away, is it okay to start ovulation induction, that sort of thing. So this is how I might dictate it. I would say left 7.1 centimeter, simple cyst, O-Rads 2. Recommend ultrasound follow-up within 12 months, which could be obtained as early as 6 weeks, as clinically indicated. I like to highlight that we include this glossary at the bottom. So if you're giving an O-Rads score, the clinician who's receiving the report or the patient who's receiving the report knows what we mean by these terms. There's also an option to include risk of malignancy, but take into account that patients are reading their reports sometimes as quickly as we sign them. So I like to include risk of malignancy for benign lesions and perhaps don't include it for more suspicious lesions, as I want to give the doctor or the ordering provider and the patient a chance to talk about the findings first. Next case. Case 3, this is a 35-year-old woman coming in with chronic pelvic pain. And as we sweep through this lesion, we see that there's 2 components, or 2 locules. So it's a bilocular cyst, right? I didn't have ready access to my phone, so I'm going to show you the other way that you can get to the management through the table, okay? Here we go. Blowing that up so you can see it. So this is a bilocular cyst. The smooth refers to the inner walls, the size here, and so the follow-up is recommended in 6 months. So how I might report it: right ovarian lesion. Feel free to include all 3 dimensions if you like, but really just one is necessary. Bilocular cyst, smooth inner walls, minimal vascularity, and internal echoes. I do want to highlight you can certainly be complete in your description with the vascularity and internal echoes, but actually for the scoring of this lesion, you don't need all those features. This is O-Rads 2, recommend ultrasound follow-up in 6 months. And now with version 2022, we have growth criteria for how to assess if it's changing on that follow-up ultrasound. And they say that if it's decreased in size on follow-up, you're done. You don't have to continue imaging this lesion. It's declared itself as benign. If the lesion is stable on follow-up, then we'll follow it again at 24 months because there's no real suspicious features. But if it increases in size, we follow it a little closer at 12 months. And how do you decide if it's increasing or decreasing? Well, we use the average linear dimension, which is the sum of all the orthogonal planes divided by 3, okay? And in this case, the patient came back at 4 months and the lesion was gone, again, declaring itself benign. Case number 4. This was a 48-year-old woman, coming in with right pelvic pain. Her last menstrual period was 2 years ago. And we see this lesion in the right ovary. And what you need to appreciate is that there are multiple fine intersecting lines. These are not septations, okay? Previously, this finding was called lots of different things, including fishnet, lace-like, cobweb internal echoes. And with O-Rads, we really wanted to get rid of these vernacular terms and harmonize the way we report this, and we now call this a reticular internal pattern. Another finding to notice here is that there's retractile collapse. These echoes are pulling away from the wall here, and that makes this a classic hemorrhagic cyst. So while I may go into more details regarding the characterization of this lesion in the findings, in the impression, I'm just going to get right to it. This is a right 5.5 centimeter ovarian hemorrhagic cyst, okay? So again, to get to that management, I'm going to pull out my calculator. Ovarian, it's a lesion, it's a hemorrhagic cyst, again with that definition right there. This patient had her LMP 2 years ago, so that makes her in that early postmenopausal period. If you're not sure what early versus late means, again, we've got that all here for you. She's early, it's less than 10 centimeters. O-Rads 2, almost certainly benign. And we have 3 follow-up options here, including short interval follow-up ultrasound, which is what I would recommend for this lesion, 2 to 3 months. And this happened to resolve on follow-up. Case number 5. This was a 39-year-old woman who came in with heavy menses. And what we see here are 2 adnexal lesions, one on the right and one on the left. What you'll notice is that they have these hyperechoic lines and dots. And on the right, there's actually a hyperechoic component with regional posterior acoustic shadowing. These are dermoids, right? And we can certainly describe the features and go into detail about size and all the features that we see in the findings. But when we get to the impression, again, I'm going to keep it short. I'm going to say there's a right 10.4 centimeter dermoid cyst that makes it in the O-Rads 3 category. And what I want to highlight that in the update, the version 2022 update for O-Rads, the management of O-Rads 3 lesions has changed. Now we have a new option for following these lesions up with ultrasound within 6 months. And that's what I would recommend for this lesion. So if not excised, follow-up ultrasound within 6 months is recommended. Now the left lesion is 5.3, so it's less than 10 centimeters. It meets criteria of an O-Rads ultrasound 2. And the management for these is found in our classic benign lesion table, which says if not excised, follow up in 12 months. And I like this case because it highlights one of our governing concepts, governing concept 3, that says for multiple or bilateral lesions, characterize them separately. They're separate entities, and management can differ, so provide individual management recommendations as needed. All right, so my impression again, remember I like to include the glossary of O-Rads categories to ensure that the recipients of the report understand its meaning, again, with the options to include risk of malignancy. One pitfall just to highlight is that interspersed air within fecal contents and bowel can mimic that hyperechoic line and dot appearance that we have as one of our descriptors for dermoids. So pro tip here, if you wait, bowel will peristall, so those echoes will move, whereas in a dermoid, those echoes should be stationary throughout the course of exam. So if you're not sure, just wait a second and it should declare itself. Great. Case number 6. This is a 35-year-old woman coming in with chronic pain and infertility. And what we see is a unilocular cyst filled with low-level internal echoes. There's some peripheral punctate echogenic foci and a fluid level. Now, people wonder, why is the fluid level arranged vertically? Well, you have to remember that when scanning in the sagittal plane, the superior part of the image correlates with the anterior abdominal wall, and the buttocks are posterior. So the echoes will layer dependently with gravity, so they'll go towards the more posterior portion of the cyst, giving us that internal fluid level. So I would certainly describe this in the findings of the report, including all the features we've discussed, but I do want to highlight that this fluid level is optional to mention. And I'm showing it to you as something that we can sometimes see. Now, we entertained including fluid level in as a lexicon term for endometriomas, but found it was not specific enough for endometriomas to make it part of the lexicon. So that's why I say it's optional. Now, when we go to management, we see that in this premenopausal patient with endometrioma less than 10, follow-up in 12 months is recommended if it's not excised. And I want to highlight that we're also including in the updated version the clinical management recommendation. This is a response to feedback from the users, as this is frequently helpful for patients following these types of exams for management of their clinical issues. Next case, this is a 42-year-old woman. She's a BRCA carrier. She's coming in for high-risk screening. And what we see is a normal appearing right ovary, and then separate from the ovary in the right adnexa, kind of inferior and medial to it, is a tubular anechoic structure with incomplete septations, endosalpingeal folds. This is your classic hydrosalpinx, O-Rads 2. Okay, and I show this case to highlight that some people wonder if O-Rads can be applied to high-risk patients, and the answer is yes, but the management may differ. And this is highlighted in Governing Concept 8 that says that Lexicon descriptors and scores apply to most lesions, regardless of risk or patient symptoms. However, management may differ. In this case, we don't really need to change imaging follow-up. This is your classic hydrosalpinx, right? But we may want to refer to GYN for management of any clinical symptoms or to address any questions that the patient may have regarding this finding. Great. Now case 8. This is a 59-year-old woman coming in with pelvic fullness, and what we can see here on the clip is a multilocular cystic lesion. There's smooth inner margins, no solid components, and no internal flow on color Doppler. All right, so you could report this as a left adnexal, 7-centimeter multilocular cystic lesion, no solid component, no internal flow. Going to management, and I like this because this is one of the longer scenarios that we deal with, so I just want to show you the longest so you can see how actually even our long ones are pretty quick to get to management. So ovarian, this is a lesion. It's not one of our classic benigns. This is a cystic, no solid components, smooth inner walls or septations, multilocular, no internal flow, less than 10 centimeters, no ascites, O-Rads 3, low risk. Now for these, management is to follow up in 6 months with ultrasound, if not excised, and these can be managed by a gynecologist. We don't need to get GYN oncologist involved. Well, this patient opted to go to surgery. She had it out. It was a serous cystadenoma, and this goes along with the likelihood of this being benign. The O-Rads 3 category is our low risk category, less than 10% risk of malignancy. So the converse of that is that it's 90 to 99% chance that this is a benign lesion, when in fact this was. Another tip here is that if the lesion is well seen on ultrasound, we have those nice clips, there's no solid components, MRI is unlikely to add anything because MRI is very helpful for helping us further evaluate solid tissue. Great. Case number 9. This is a 49-year-old woman coming in with irregular menses, and what we see is there's just one little suspicious thing here. It's a small area right there that meets criteria for a papillary projection because it's projecting 3 millimeters into the cyst lumen here. So this is a unilocular cyst, 1 papillary projection. We go to our tables. That meets criteria for an intermediate O-Rads 4 lesion. And now the options for follow-up of this are to get an ultrasound specialist involved, an MRI, which is especially helpful when there's solid tissue, like in this case, or for GYN oncology or gynecology. Now this patient opted to go to MRI. There was no papillary projection or solid tissue seen, so it was actually downgraded to an O-Rads MRI 2 lesion. She came back 2 months later for another ultrasound just to see how things are going. And again, we see that small papillary projection within this unilocular cyst. It even has internal arterial flow on spectral Doppler. So what do? You report it the same way. So unilocular cyst, 1 papillary projection. This is an O-Rads ultrasound 4 lesion. And I like this case because I think it's helpful to demonstrate that while in general, we say that O-Rads MRI scores will override an O-Rads ultrasound score due to improved specificity of MRI, that's not always the case because we know that the slice thickness limitation of MRI, they're just thicker slices. We can actually miss some of the solid tissue when we go there. So in this case, the ultrasound score is actually more reliable because of the improved resolution. So with this knowledge, we would recommend consultation with GYN oncology, gynecology. She ended up having this out, and this was a borderline serous cystadenoma. Again, the take home here is that when papillary projections are really small, or the finding of interest is really small, MRI may not demonstrate it due to slice thickness limitations. All right, this is the last one, case 10. This is a 70-year-old woman coming in with weight loss and bloating. And what we see here is ascites, it's fluid extending to the uterine fundus and then the pouch of Douglas. She also had a right adnexal mass, which we could see transvaginally, but got a better look at transabdominally. And we can note that the margin, the outer margin of the solid mass is irregular. And we're talking about solid lesions. The outer contour is super important. And once it's solid and irregular, it's straight to O-Rads 5, high risk. So in this case, we recommended referral to GYN oncology, who opted to have a CT scan as part of her staging and workup for her disease. Not only on that CT could we see the adnexal mass and the ascites, but it also highlighted the omental caking or metastatic intraperitoneal disease. So this proved to be a high-grade serous carcinoma, and the tip here is that not all O-Rads ultrasound 5 lesions need additional characterization with MRI. It's perfectly appropriate to refer these patients straight to GYN oncology, and then the oncologist, in conjunction with the patient, can come up with additional imaging recommendations if needed. The short pitfall for this is that whenever you see a solid lesion in the adnexa, be sure you figure out where it's coming from. So here's a case where you see a solid mass. The question you want to ask yourself is, are there ovaries separate from this? And sure enough, there are. Sometimes you have to go transabdominally to see them if you're transvaginal, but make sure you're taking lots of really good care to see if there's an ovary separate from it. So if you see separate ovaries, you want to take a look and say, well, where's the blood supply for this finding coming from? Look for those bridging vessels. And sure enough, there's bridging vessels coming from the uterus towards this, now we know, pedunculated myoma. So this is not actually ovarian, this is uterine in origin, and this highlights governing concept 1, that the intent of O-Rads is to stratify the risk of malignancy for ovarian and tubal findings, and is not applicable to exophytic or broad ligament fibroids. So for these, you don't need to give an O-Rad score. Now, we know some cases are more challenging than others, but we hope we have provided some helpful implementation tools to elevate your game. These include our calculator, our algorithm, and charts. Please also check out our website for even more information. So that's it for me, but before I hand it back to Lori, I want to thank her for her mentorship and also for sharing cases for this presentation. It's been an absolute pleasure to talk with you today, and with that, back to you, Lori.
Wow, that was absolutely fantastic, Katie. Thank you for those pieces. They were so instructive. So let's summarize.
O-Rads is both a lexicon and risk stratification management system. Ultrasound is our first line imaging, with MRI reserved as our secondary tool. These are complementary, but MRI is more specific. So in general, an O-Rads MRI score will override your O-Rads ultrasound score. We will be having an O-Rads MRI webinar, so look for those dates. That should be coming soon. For O-Rads ultrasound, strictly adhering to the governing concepts and the lexicon is key. You want to strike complex, heterogeneous, indeterminate from your lexicon. This is an algorithmic approach. Not all features are relevant for scoring. In terms of implementation in your practice and image acquisition, I want to encourage you to have your sonographers obtain those orthogonal cine clips through and through the lesion. Optimize Doppler by adjusting the scale and using your color Doppler box just to the region of interest, and then train your sonographers how to measure things accurately. So maximum dimensions, as well as the height of protrusion into the cyst cavity to determine if there's focal thickening, which qualifies as a solid component. For assessment and management, you want to print or laminate the tables and algorithm, have easy access to the website, and download the app. It's really a time saver. In fact, you can use all three. That would be the trifecta, and you will be ready to go rads. So with that, I thank you so much for your attention and your interest in O-Rads, and we are now available to take your questions.